Thank you, Alaric. I think counselors can pass this around. Everybody should have a feel of this. Not changing. Only.
This mic has to be outside.
Hmm?
It has to be outside.
Okay, so first thing, what you're holding in your hands is a model of an adult foot. It is a not the model of a child's foot. So that's one issue we have in this. If you were to look at a child's skeleton, all you would get are small ossific nuclei. They are small blebs of bone. And depending on the age of the child, the number of ossicles will vary. Here you're seeing all the bones in the adult foot. And how many are there? How many bones are there? 26 in an adult foot. It's simple to remember letters of the alphabet, 26 bones. So that's there. But in a child, you will just get the talus, the calcaneum, and depending on the age of the child, you will see the navicular, the cuneiforms, medial cuneiform, lateral cuneiform. It changes with age. Just out of compulsion for understanding the kinematics of the subtalar joint, this has been created. And when I started doing Ponseti way back in the late 90s, 97, 98 to be precise, after reading an article in 𝐬𝐨𝐥𝐿, the Dietz and Cooper article, I started it and I felt maybe this is good, an exciting method, casting technique. I used to run the Clubfoot clinic in my hospital at that time, mostly kites method, and this looked promising to me. I did not understand the true kinematics of the foot. 2000 also I did not understand. I started doing, I was very happy with the results. I was not doing tenotomies, I was doing TA lengthenings. Good results. But I did not understand the kinematics until this came into my hand. Once I started handling this, then the eureka moment came. And I realized what is the basis of Ponseti's method only then. That's why this model is an important addition to training and understanding Ponseti's method. And you will understand why I am saying so. So first thing is, there are certain key things you have to remember here. If you see this, that's the calcaneum, that's the talus sitting on top of the calcaneum. The calcaneocuboid and the talonavicular joints are exactly at the same level. You don't think of it, it's exactly at the same level. Okay? And the calcaneocuboid joint is perpendicular to the long axis of the foot. The calcaneocuboid joint is perpendicular to the long axis of the foot, and as much as the talonavicular joint is perpendicular to the long axis of the foot. You have to get this right. The arches of the feet are there, the long axis, the medial longitudinal arch, the lateral longitudinal arch, and the transverse arches. Okay, all that are there. But if you look at clubfoot, the acronym that is used to describe the deformities in clubfoot are CAVE. the cavus, the adductus, varus and the equinus. Cavus, adductus, varus and equinus. So each of these components that you see here, that it's turned in like that, the adductus. Here you have the cavus there, the hind foot is in varus and the equinus that is there. The CAVE acronym is appropriate for Clubfoot. Ignazio Ponseti was a Spanish orthopedic surgeon who trained in Barcelona University, and at the time of Civil War he moved to Mexico. And from Mexico, a Hispanic speaking population from Mexico moved to the Midwest of USA. Midwest of USA is the granary bowl of USA where maximum agricultural activities take place. It's important to recognize that because agricultural people are rooted to the ground. Farming population are rooted to the ground. They are not like the IT professionals that get trained in Delhi and wherever else, then move to Bangalore, and from Bangalore move to Seattle and San Jose and other places world over. They keep moving. The farming population is rooted to the ground and therefore they are ground based. The important thing is they are not moving around. So Ignazio Ponseti started working in Iowa University. In Iowa University, the rural population, the incidence, if you look at the incidence, they will have a certain number of clubfoot children being born, and therefore they would go to the university hospital. And so he knew the follow-up of patients that were operated before, that had 𝐤𝐸's method before, and he knew what was happening to his results. And he was not happy with the results. And he was not happy when, more so because he read an article by Robert Jones which said that a clubfoot treated correctly should be corrected in 3 months' time, and he could not get that. He said, my results are not good. Why are my results not good? So he started studying. And in the process, by sheer serendipity, in the labor room, he heard of a stillborn baby born with clubfoot. So he took permission from the university authorities to dissect this stillborn baby's foot. And this is that foot that he's dissected out, trying to understand what is abnormal in a child with clubfoot. And he found that the navicular is wedge shaped. It's not the usual navicular. It is not that shape that is expected to be. It is wedge shaped. The navicular is moved closer to the medial malleolus, shifted medially. The head of talus is lateral, the navicular is medial, coming close to the medial malleolus. I still remember when we were doing posterior soft tissue releases, Dr. Sita Gupta, my teacher, showed me, look Dr. Mathew, there is the medial malleolus almost has a facet on the navicular to articulate. It's that close. That severe a deformity was there, coming so close to the medial malleolus to almost articulate with the medial malleolus. That is what was there. So navicular moves medially, and then there is severe equinus in the ankle joint. The talar neck is inclined medially, but the head is lateral. That's how it is. The calcaneum is inverted. The calcaneocuboid joint is obliquely placed. The cuboid is wedge shaped. Cuboid is displaced medially. See, all these anomalies are there. But they are all in the cartilaginous bone. All that you see is all cartilage, it's not bone. You just have small blebs of bone if you get an X-ray done. We don't want to get X-rays done in these feet. The feet are predominantly cartilaginous. Quite unlike the long bones and quite unlike the short long bones, they do not have growth plates. So ends of femur, ends of tibia, you have growth plates. Ends of the metatarsals, you have growth plates. But the tarsal bones don't have an ossific nucleus. The cartilage of the articular surface of the navicular, which means the talonavicular joint, the navicular cuneiform joint, is the growing end. So the articular cartilage is pari passu with the growth cartilage. So when do you know the foot is mature? You look at the talonavicular joint. If the gap in the talonavicular joint is more than 4 millimeter, you know it is an immature foot. If the gap is less than 4 millimeter and close to 2 to 3 millimeter, you know it is a mature foot. So when you want to make a decision on triple arthrodesis, in a girl child about 12, you get an X-ray done and see if the navicular talus gap is about 2 to 3 millimeter, you know it's a mature foot. An immature foot, wide cartilage, wide resection of cartilage, pseudoarthrosis chances are high, foot shortening is high. You don't want to do that. Therefore, you need to recognize that these feet, they are all cartilaginous, and therefore, once you correct the cartilaginous portion of the foot into a normal weight bearing portion, then the cartilaginous analog grows to be normal. If the articulation is abnormal, the growth is also abnormal because the articular cartilage goes with the growth cartilage. That's the reason early correction, normal feet, late correction, less than normal feet. Early correction, normal foot length, late correction, abnormal foot length because the growth pattern is abnormal. That's what you have to recognize. So these anomalies were understood and studied by Ignacio Ponseti in the 1940s. That's when he went to Iowa City. Today, this specimen is preserved in the museum of Iowa City Hospital, Iowa University Hospital. And that university is now popular for two things. Famous, not popular, it's famous, it's now popular anyway, but it's famous for two things. One is this, Ignacio Ponseti's method that has now revolutionized Ponseti's method of treatment. The second is the Iowa University literary workshop that they do. Just produce 9 Nobel laureates. 9 Nobel laureates in literature. It's famous for the Iowa University literary workshop that they do. So Ignacio Ponseti is one of the persons who's been described as who deserved a Nobel Prize but never got one. Who else has been described as having deserved a Nobel Prize in orthopedics? John Charnley and Elizarov. So 3 people in orthopedic surgery who deserved a Nobel Prize did not get it. All 3 are no more. Okay, the closest was one of the persons who trained as a resident in orthopedic surgery, was part of the discovery of insulin, a Canadian orthopedic resident who won the Nobel Prize for discovering insulin. So that's the only one, the closest an orthopedic surgeon has get to a Nobel Prize. Okay, but here we have Ignacio Ponseti understanding the pathology, and he felt that the abnormal thing in clubfoot is, so the model, if you see, is exactly the same shape as the foot, is exactly the same shape as a severe idiopathic clubfoot. That's what you have. And when you look at the MRIs, it confirms what you get in this model. And what is it that it's confirming? It is confirming that the hindfoot is in significant varus. It is confirming that the inclination of the talar neck is there. It is confirming that the navicular has come close to the middle malleolus. MRI is confirming that the calcaneocuboid joint is oblique. MRI is confirming that the cuboid joint is displaced medially. It is confirming all the things that you see in the model, all the things that you see in the clubfoot child. All of them are there. Okay? And when you look at what Ponseti's understanding was, he felt that there is something abnormal in the posteromedial soft tissues of the clubfoot child, which he termed as the retracting fibrosis, a fibrosis which is retracting, which tends to keep the feet in that deformed position. And he felt that as the child grew older, after correction, the tendency for recurrence kept going down. So early cases, first year the recurrence rate was very high as 49 to 51%. Even in the hands of the master, the recurrence rate was very high. And as years rolled by, the recurrence chances kept going down 20%, 15%, 6 months, didn't become zero. So it remarkably reduced after 4 or 5 years, and that is why the brace protocol that we have is based on this tendency for the retracting fibrosis to cause deformity to recur, that we have the brace protocol extended up to 5 years. Earlier it was 1 year, then 2 years, then 3 years, then 4 years. Now it is current recommendation is 5 years, and there are literature support which talks about the extension to even 6 to 7 years in those children with dynamic supination. We'll talk about it when we talk about the foot abduction brace. Okay, so that's what Ponseti said. So once the foot is not corrected, left untreated, then the child begins to walk. And when does the child begin to walk? Standing is 8 months or so, 8 to 10 months. Walking is 13 months average. But if you look at the Gaussian bell of normalcy, there is a spectrum. So if you go to a well baby clinic, mothers would proudly be saying, "Mera nanna to 10 mahine mein chalne lag gaya." But that's not the norm. That's a tail, the early tail. The Gaussian bell of normalcy has the other tail also. तो वो बच्चा जिसका नन्ना चलने नहीं लगा 13 months में, is that abnormal? No. Up to 16 to 18 months is also normal. But that spectrum is there. In that whole spectrum, once they start to walk, then the growth of that cartilage, the foot growth has 3 phases. Early rapid growth phase, a slow phase, and then again secondary rapid growth phase. The early rapid growth phase, there is this phase when the child's foot will have a structural abnormality coming up the longer he walks. Okay, so this is an adult foot, untreated. All the bones have developed abnormally. The shapes are abnormal. The articulations are abnormal. All of it is abnormal because the growth of the cartilage has gone with the articulations that have been abnormal. So you know the importance of early correction? That's why you have to have early correction. So the key to Ponseti's method, technique is to understand the kinematics of the joint, the subtalar joint. So in this connection, Ponseti described 2 things based on his reading of literature. And that is, first thing is what Farabaugh described as the calcaneopedis unit. The calcaneum and the foot block. It's one block. It works as one unit, the calcaneum and the rest of the foot. The talus is fixed in the ankle mortise. The talus is fixed. Talus is not moving. In your movement of your subtalar joint, the talus is fixed, the subtalar joint is moving. Okay, so the calcaneopedis unit functions as one unit. In that one unit, we have what is known as the talonavicular joint here. Now the talonavicular joint, the ball of the talus is fixed, and here it articulates with that cup which is there, which is consisted of navicular, the anterior subtalar joint, the middle subtalar joint, the plantar calcaneonavicular ligament, the capsule of the talonavicular joint. Altogether constitutes what was described as the acetabulum pedis, or the acetabulum of the foot. The only difference is, normal acetabulum is fixed, is the ball that rotates within the acetabulum. But here the acetabulum is moving around the ball of the head of the talus. That's the first thing. So this is the dynamics that you have to understand. That's the posterior subtalar joint, that's the mid subtalar joint, that's the anterior subtalar joint, that's the navicular. That's the acetabulum pedis that is formed. Okay. Now coming to the kinematics. To come to the kinematics, you have to understand this anatomy of the calcaneopedis block functioning as one unit. Calcaneopedis functioning as one unit. Herein you have to understand what Ponseti took a little time in his historical leading of literature. And he read an article by Farabaugh. Farabaugh had written an article in 1872. Passion. 150 years back. This man has written an article and it's still relevant. I mean, look at his genius of thinking process, that we still are struggling to understand the subtalar joint axis and rotations. And here is this man in 1872 without x-rays, without anything. X-rays were not discovered at that time. He understood that. This is how it seems to work. And he likened it to this boat on the surface of water. Look at the way the boat is moving. Is it moving in one plane? No, it is moving in several planes. Is it moving in one plane at one time? No, it is not moving in one plane at one time. It is moving in several planes. And I have made an origami model of a boat here. And imagine this boat is moving on the surface of water. As it is moving on the surface of water, is it moving straight? No, I'm not talking about the speed boats that you see on the surface of Venetian waters where James Bond is chasing a villain. Okay, zip, it goes across on the surface, sometimes even floating off the surface of water. No, I'm not talking about that. I'm talking about a canoe on the surface of water which has no power, being paddled with a paddle. This boat, as it is moving forward, it keeps going up and down with the waves. The sailor would use the expression, sir, the boat is pitching up and down. Pitching. Is that the only movement? No, you can see that there is a three-dimensional movement there. The boat is also rolling from side to side. Can you see that? It's rolling from side to side. Is that the only movement? No. As this is happening, a wave comes, it's going forward, a wave comes, blows it this way. So the sailor corrects it to straight. Again it blows it this way. Again it corrects it. So yawing from side to side. So the three components of movement happening in a boat, that is pitching front to back, rolling side to side, and yawing side to side like that. Three movements. Are they happening independently? No, they are happening simultaneously at one plane. Exactly on the surface of water. All of them are happening. Now I didn't understand. I didn't understand what is the connection with this. And that until I handled this model. That's for me the 𝐬𝐸𝐴 moment. Once I got the model in mind, I said, oh my God, why didn't I think of that? And that genius, Ponseti, was able to recognize this way back just by reading that article. He didn't have this model. This model was created by Ignacio Ponseti's orthotist, John Mitchell. He was his orthotist all his life. And he requested him. Ignacio Ponseti was not a great speaker. He was a Spanish descent. He was not great in English. He didn't give great lectures. But his wisdom was remarkable. And he asked John Mitchell, can you make this model like this? And John Mitchell made this model for them. So once you see this model, you need to learn how to handle this. The right foot model, I don't know which side, most of them are right, I think. Hold this. You don't hold it like this. You hold it like this. So that your thumb comes to the fulcrum. The fulcrum is the talar head. Okay, so you need to recognize the fulcrum by getting your thumb onto the fulcrum. And how do you get your thumb on the fulcrum? Feel for the lateral malleolus and go in front like that. In front, not below. Below is the calcaneum. Not below and in front, but straight in front. Straight anterior. So you get the head of the talus there. That's your first setting the fulcrum. And then the manipulation of Ponseti comes up. So normally you have the 𝐬𝐸𝐴. Can you see this model? So when I do pronation, this is pronation, isn't it? This is pronation, this is supination. Pronation and supination. When you pronate, what happens to the 𝐬𝐸𝐴? Getting exaggerated, isn't it? A pronated foot, the 𝐬𝐸𝐴 is exaggerated. A supinated foot, the 𝐬𝐸𝐴 is decreased. So that's the first step. 𝐬𝐸𝐴 is decreased by supinating the foot. Why should pronation be there in a foot? Pronation is naturally there because the plantar surface of the foot is designed to be the weight bearing surface. The foot skin is different from the rest of the body. The foot skin is like the palm skin because we were supposed to be walking on our feet and hands, no, isn't it? Quadrupeds were there. Evolutionary, if you look at evolutionary biology, we are on all fours. And all fours, we were having special skin here. Hooves were there initially, but then shifted to special skin. Okay, and this skin doesn't slip. The skin of the dorsum of this hand and foot, it slips. It's not tied down by fibrous bands. So this is a non-slipping skin, and that nature evolutionary happened more than 4.5 million years back. First step of a bipedal human being is 4.5 million years old, and that has taken so many years to be weight bearing. So if the foot is not weight bearing, posturing like the way a normal foot should be, then nature tends to take it into pronation to encourage weight bearing of that plantar surface of the foot. Therefore, natural tendency, if the hind foot and the forefoot is in varus, natural tendency would be to take it into pronation. Can you see that? Natural tendency. So, the hind foot is in varus, the forefoot is in pronation, naturally evolutionary tendency. So, what do you have to do? Get the forefoot in line with the hind foot. That's by supinating the foot, by doing the supination. Simple? Now, that brings the forefoot in line with the hind foot. Now, how do you correct? The foot is in varus like that. Now, how do you correct? You abduct this with the thumb on the fulcrum, keep it like that and then abduct. Then see what happens to the hind foot. The hind foot varus naturally corrects. Can you see that? I am not touching the hind foot. I am not touching the calcaneum. It's naturally correcting. See that? Supinate and it's naturally correcting. You can try it out yourself. Your friend can hold it for you between yourself. Try it out and check it out. Hold it like that. Supinate and abduct. The hind foot varus is corrected naturally. So the forefoot adduction is corrected. With the thumb on the fulcrum, you supinate the foot and then abduct the foot. That will correct the hind foot varus, forefoot adduction, and the forefoot equinus gets. So I again could not understand where is this boat analogy coming up until I handle this model. So what is the model telling you? Once you have your thumb on the fulcrum, you roll the foot into supination, yaw the foot into abduction. The pitching correction of the forefoot equinus happens naturally. The final pitching correction of the hind foot equinus happens with tenotomy. So simple. So simple. So once you know this kinematic coupled movement of the calcaneopedis block as one unit, you have forefoot is rolled into supination by keeping your middle finger under. I was taught this by Dr. Ponseti, is a master. In fact, people like Dr. Norgropini and Shafiq Pirani, they say that his hands are like Michelangelo, shaped like that of a correcting, manipulating hand. Dr. Pirani taught me, you put your middle finger under the plantar surface of the first ray, thumb on the fulcrum, the middle finger on the plantar surface of the first ray, and abduct the foot. Abduct the foot. First ray using your index finger. So this is plantar surface, this is medial surface and abducting. When you do that, then the foot abduction naturally happens with correction of hind foot varus and forefoot equinus naturally correct. So simple. Once this is there, you have internalized this, you know each time. Some people say, sir, pehla cast to supination hota, baki cast to sirf abduction. No. Until the foot is fully corrected every time, right from the first cast, which is it's not only first cast in supination, the first cast is also in supination and also in abduction. You don't want to keep it in adduction. Supination and maximum abduction correction is done. Each time it's supination, each time it is supination and abduction. Just remember that. Each time it's the same maneuver. Supination, first step, lateral malleolus reference point. Second step, head of talus, the fulcrum identification. Third step, middle finger on the plantar surface of the first tray. Fourth step, index finger on the middle side of the first tray. And the fifth step is abducting this foot. If you make a mistake, if you pronate and abduct, nothing will happen. See that? You pronate and abduct, nothing happens. The hind foot correction doesn't happen. It's designed brilliantly. You pronate and abduct, nothing happens. If you dorsiflex, again you are in for trouble, nothing happens. No correction happens. So you need to understand there is no pronation, there is no dorsiflexion. These are key performance indicators when you do this. And to be very clear, thou shalt not pronate the foot, thou shalt not touch the calcaneum, thou shalt not dorsiflex the foot. These are key indicators to be sure that your manipulation is right. So get the fulcrum right first, and reference to the fulcrum is the lateral malleolus. Anterior to the lateral malleolus, 1 centimeter in front in a child. This is an older foot. I wish we had there are smaller models available, but we don't have numbers like that, but they are available there. Okay, and with that you can demonstrate so easily. This we need 2 hands to do it. So raise it up, abduction and correction. Once you understood this, the whole process of Ponseti's method becomes absolutely simple. And that's Ferabauf's article 1872, roll, yaw and pitch. So simple. It makes it elementary. And this whole movement is not in one dimension, it's kinematically coupled, happening simultaneously. And that's normal subtalar joint. So that's the normal hind foot of an adult 18-year-old girl. If you look at the foot, when the foot is plantar flexed, inversion and adduction, that's the typical clubfoot maneuver. That's a normal movement that is possible. So you have that when you have plantar flexion, happening. When you dorsiflex, there is eversion of the hind foot. When you plantar flex, there is inversion of varus of the hind foot. When you dorsiflex, there is valgus of the hind foot. Eversion happens. When you abduct, hind foot goes into varus. When you adduct, hind foot goes into varus. When you abduct, hind foot goes into valgus. Normal, kinematically coupled movements. Normal. It's not abnormal foot. Okay. When you're standing quietly, hind foot is in valgus. When you stand on tiptoe, hind foot is in varus. So plantar flexion goes with varus of the hind foot. Dorsiflexion goes with valgus of the hind foot. Normal, kinematically coupled movements. So that's how the model is designed. When you abduct it, the forefoot adduction gradually gets corrected, forefoot equinus gets corrected, and the forefoot supination gets corrected. And you have the natural movement happening. Okay? And that's exactly how the subtalar joint of a child with clubfoot is manipulated to get into the right position. And as you put serial cast weekly, now the question comes, why weekly cast? Why do we have to have a weekly cast? So what Ponseti's understanding was, this retractile fibrosis tissue that is there, that correction, you stretch it. And the stretchability of this returns. So he called it the crimp. So there is a creases, there is a crimp there. You stretch it to the limit. But if you stretch it too hard, there will be break in these fibers. So if you stretch it too hard, the child will cry. We don't want too much of force. If you have too much of force applied, then the internal ligament fibers break. Child has pain. Nociceptive stimulus is excessive stretch. Why is there pain? Because there is harm happening inside. Tissues are breaking. Minor albeit, but there is a breaking happening. Put too much of pressure, there is scarring that comes up. Scarring means recurrence. So if you do forceful manipulation, it will look correction very happily, very nicely, very early on. Oh, I got it corrected in 3 casts. By using brute force, no, it won't be good, it won't last. It will recur. So forceful correction leads to recurrence. That's why we don't encourage anesthesia correction. Under anesthesia, you may use excessive force. Child won't cry. You may use excessive force, and therefore you may have earlier recurrences. We don't want that. We want gentle manipulation, and this crimp of stretchability comes back in a week's time. So can we put a cast in 5 days' time? Yes, we can. Can we put a cast in 10 days' time? Yes, we can. But why not 2 weekly? You are unnecessarily prolonging treatment. Why not less than 5 days? Because the crimp does not return for repeat stretchability. So it's stretched to the limit, but not beyond limit. Keep it for a week. Biological tissue, the crimp returns for a fresh stretch. Next time, return for a fresh stretch. Each time, it's like you are bonsais. You talk to these people that do bonsais. They have a stiff wire with which they mold the branch to the limit of short of breaking, and then leave it there for some time. And after that, little more bending, little more bending. You get into all kinds of grotesque shapes of manipulation. It's exactly like that. And Hippocrates used the term molding it like wax. Molding it like wax. That's what Hippocrates showed. And that's what we are doing. Gentle manipulation, stretchability comes back, repeat manipulation. So it's convenient for us to do a weekly casting. And therefore, we have this correction happening over a period of time. So serial casting, and if you were to see, the first cast appears to be maximum supination. The second cast is less supination, less adduction. Third cast, still less supination, little less adduction. Then neutral, and then abduction. So gradually the supination is gone, the abduction has come up. With serial casting, increasing abduction, decreasing supination. That's the sequence that we have. And therefore, by around 5th or 6th cast, you're ready for a tenotomy cast. That's what we have. Is it clear now? But the first cast looks so much of supination. So many patients like, Doctor Sahab, apne to pair teda kar diya. So in Indian condition, it's easy to explain to the parents, zehar ko kaatta hai. Okay? The homeopathy people, the low potency poison for a high potency disease process causing organism. So in Indian culture, it is easy to explain to them, ye aur isko teda karke aur seedha kar denge. Don't worry. You can reassure them. Counselors are trained for that. They'll tell them कि ऐसा होता है, पहला टेढ़ा लगता है, फिर बिल्कुल first class टेढ़ा आ जाए, सीधा आ जाएगा. That's what we guide them on. And kinematic coupling, look at that. That's a dynamic CT scan which shows you how the normal kinematically coupled movement of the foot bones are. That's how it is. Look at the way it goes. It's just supination and abduction that is happening. Look at the way the hind foot moves from varus to complete valgus. Look at the way you see it from the side view. Again, it moves as you abduct, it goes from varus to valgus position. That's what we have. See the hind foot. All that is being done is abducting the supinated foot. Hind foot varus correction is happening automatically. It's an automatic correction that's happening. Okay? Why 70 degrees? Because a normal infant's foot can go up to 70 degrees of abduction. That's why I need 70 degrees of abduction. That's the normal child's foot abduction capacity, and we are trying to restore normalcy. Okay, so for normalcy, 70 degree abduction is required, and we are restoring normalcy. Okay, as normal child, infant. But in an older patient, the abduction may be less. That's what it is. So here it is. If you pronate, no abduction will happen. If you touch the calcaneum, no abduction will happen. So that's touching the calcaneum and abducting, no abduction will happen because it's kinematically coupled. The abduction will cause hind foot varus correction only when the calcaneum is free to move beneath the talus. That's the key thing to remember. You have to also remember that the calcaneocubitus joint, which was the fulcrum in the manipulation by 𝐸𝐷𝐻's method, here it is moved 1 centimeter medially to the talocalcaneal joint. So they say that it took 60 years for the fulcrum of manipulation of the foot to move from the calcaneocuboid to 1 centimeter medially to the talonavicular joint. 60 years for 1 centimeter movement. And so many things happened in between historically. Thank you very much. So any questions on this? This is very basic, you have to understand this. So the next session on the hand positions becomes very simple once you understand this. All of you must handle it yourself and see how it moves and how to do the manipulation. Is it clear? Thank you. I'll stop here. Alaric, take the hand position. Are you good enough? Yeah, speak.
What is the reference line in abduction of hind foot?
Sorry?
Sir, what is the reference line taken in lower end of tibia fibula that this is adducted or this is abducted?
Reference line for adduction and abduction. What is, that's the head of the talus, that's supination, and what is the reference line for axis of the foot? The second toe. The second toe. So you take that as this reference line. So how do you measure the degree of abduction? Now, there is a little problem here. How do you make sure that the degree of abduction is measured consistently, intra-observer reliability and inter-observer reliability? There are different ways of doing it. You can do it in the prone position, you can do it in the supine position, you can do it in hip flex 90 degree, knee flex with reference point the tibial tuberosity. But whatever you do, you're looking at the second toe to be abducted beyond the axis of the ankle joint middle point. Okay, so your talus head is here, it has come there, and the second ray abduction in line with the axis of the leg, how far it is going out. That is what it is. So you look at 70 degrees in relation to the axis of the leg. Okay, somewhere in the middle of the ankle joint. That's where it is. But the exact measurement, there is no consensus on this. There is a group formed by Dr. Pirani on this. It's called the angle group, which is trying to look at the most reliable method of measuring the degree of abduction. Okay, there is no consensus so far on this. Good, you raised that point. Any other question?